Hi, this is Shriti from Rockville, Maryland. Get ready for your unofficial dental hygiene podcast.
These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
96. Good Sunday morning, Michelle. How's it going?
My coffee's downstairs.
That is
coffee.
Too bad. I'm sorry.
But good morning.
It's
good
early.
Sunday morning.
Good Sunday morning. It is 7.
It is early for you. It's not so much for me, but I also have just come back from ADA.
Tell me all about it. How was it?
These meetings kick my butt. Oh, it's always fun to see my friends. Well, our friends too, really. What's funny is that, we are so involved in dentistry and all these shows. Like, even my friends are like, oh, you got to go to another conference. And I was like, yeah, but all my friends are going to be there. I'm excited to see them.
Yeah.
So I do enjoy it. The meetings are exhausting. I didn't have to work a booth, so that's good. But the day just literally disappeared most days. The exhibit floor was huge. So walking around seeing, I'm sure there was tons of people that I didn't even talk to because I totally missed their booth. I did get some really good information that will help me on my mission trip. And there was a few dental missions groups that had booths there, which I've never really seen at these things. So I found a new way to sterilize my instruments on the go. I found some new chairs I'm going to try out. So a lot of things, all good stuff.
Very nice. That's way awesome. Although, I feel like there's going to be that one dental office that's going to be like, oh, if they do that in the mission trips, I can just use that for my office here in the States, and won't have to pay as much money to sterilize my instruments, and I won't have to buy an autoclave. And there's going to be one person that's just going to try to pinch a penny and just not do it the right way. You just know that's going to happen.
I did walk up to, so there's this handpiece company, and I have 3 different handpieces that I have just kind of acquired through the years, and I use them at my outreach program, right? Mm-hmm. One of them, of course, is Young. Love that handpiece. One's a Midwest, nice. And one is a company called Lars, Lars.
Never heard of it.
Yeah, they're apparently a new kid on the block, because when I walked by, I was like, love your handpiece. They're like, tell everyone. I was like, okay. But it's actually pretty comfortable, ergonomic, and it spins easy, which is always my thing. Ones that get kind of stuck, and it pulls on your wrist, I get really annoyed by that. So this one is really, it spins. They come in all these colors and whatnot, whatever. So I walk up and I was like, oh, I will. And they're like, oh, so are you changing your handpieces between patients? I was like, how many of the people are saying no? Because I do. But I'm sure that's probably a question you have to ask a lot of offices, because, again, you're going to have the ones that pinch pennies, and they're going to find a way not to have a Statum or something. They're going to use this pressure cooker or something ridiculous. So it was good. It was a good show. Like I said, a big exhibit hall, but I got to see Dr. B from Passionate Dentist, our buddy. Did a recording with him. Yeah.
Shout out to what do you want me to call him? Not doctor anymore. He wants me to call him Stud Bilal, or super chick magnet Bilal, or something like that. Shout out to him.
I like that.
Not doctor.
They're
sorry.
so funny. Not doctor. We saw, of course, our friend Sarah and all our friends at PDT. Of course, American Eagle wasn't there, but just all of our friends, Valerie from Georgia Dental Hygiene Association. She was working at Invisalign. Elijah. The whole crew was there.
Sounds like I kind of missed out on
everywhere I turned,
something.
I was like, I didn't know you were here. Yeah, it was interesting. So good stuff. Good stuff.
Good. I have almost zero to report to you this week. I traveled, I worked a lot. I wasn't feeling very well this week, and so I did a lot of going to bed early. I have a lot of travel next week, and then Zach and I are actually going to go down to San Diego. I need to do a miles run real quick because I'm short by about 1,200 miles for status. Okay. And so I was like, Zach wanted to go somewhere for his birthday anyway. I said, okay, nice. Like, where do you want to go? And round trip from Portland to San Diego is $150.
Nice.
And so I'm like, buddy, we can go to San Diego, but it's going to be a quick trip. It'll be like 2 days, and then we're back up. So.
Oh, that's fun, though.
Yeah.
It's funny you say that because my goal is diamond status. I'm platinum right now.
How far off are you?
I think I'm going to be, I don't know how likely it is, but if I have to buy the miles or take like extra flights like you're doing, I'm definitely doing it because after 2018, so if there's any Delta people, if you can learn anything from my ridiculous amount of flying, what year are we? We're 2017. So 2018. So currently to get status with Delta, and I think this is a lot of other ones, I know this is pointless to dentistry, but there might be some people that take a little pearl from this, but you have to have like qualifying miles and qualifying dollars.
Right.
And then qualifying dollars is either going to be on your American Express Delta card, either like 25,000 total for the year, or you have to have so many qualifying dollars for each kind of upgrade your segment, right?
Right.
Like platinum, gold, whatever.
Which is pretty standard across the industry, though. You do have to have those types of stuff.
However, and that means 25,000 total on your credit card can get you gold, platinum, and diamond. Mm-hmm. So when 2018 rolls around to get platinum and diamond, they're changing that to $250,000 total on your credit card. So let's just go ahead and say that Michelle's not getting diamond status after 2017.
No, not at all.
So I really just need to have 1 year of diamond status in 2018. Say I've done it and call it a day because I'm not getting it. I'm not spending $250,000 unless I buy a house down here in Charleston or something.
Yeah.
Or a plane,
That's
something
insane.
crazy.
Well, good luck with that one.
Thanks. Anyway, so I do have one dental thing, though. I did learn that Elevate Oral Care, which is the one that has the silver diamine fluoride arrest, they have tinted their silver diamine fluoride, so you can actually see if it goes anywhere else.
Oh, very nice.
So it's like a light blue. So for all those people that were worried that like they were going to get it on other teeth and turn other areas black if they didn't know they had incipient lesions, blah, blah, blah. Mm-hmm. I mean, I'm also just the jerk that doesn't care about the aesthetic side. I'm like, you have decay, kill the decay. Like, who cares if it turns black? It was going to turn black anyway. But I also realize that that kind of messes up restorations. So I try to keep that in mind. I've heard that. Like, it will stain it a little bit and your restorative isn't great. Is that true? Do you know?
Well, I mean, we can get into a whole debate on that. There are going to be people that say both things. It's just like everything else in dentistry. Does it ruin? No, it doesn't ruin. It can affect bonding, though, underneath. But, like, if you have, like, a composite and the margins of it has a little bit of decalcification, it's going to stain there because it's a weak area. It's just, that's what's going to happen.
Right.
So, sorry, but kind of not really.
You know how I never really want to talk restorative with you? This is actually a moment where I do, because I'm going to Nicaragua, right? And I'm going to take, I can take a triturator and glass ionomer finally.
Yeah.
Like I'm going to have electricity. So this is kind of changes the game for me, and it's forcing me to step up my knowledge on the restorative side. What kind of, okay, God, I hate being so ignorant with this now. I don't know all the terminology for like the equivalent of a Tafelmeyer. Mm-hmm. Like, how do you normally keep all that mess when you have like a class 2?
So do you have a dentist that's going to be prepping while you're down there?
No. So we're just scooping it out and honestly, packing it in.
Okay. So if the hard part's going to be is if it's like a true class 2, a lot of times that occlusal portion will still be intact. And so when the dentists do the prep, they go through healthy tooth to get down to the mesial, the distal portion, creating a class 2 prep, right?
Okay.
Not a lot of times is that whole distal or that whole mesial portion also compromised all the way from interproximally all the way up through to the occlusal surface. And so if you guys are doing scoop and fill stuff,
Yeah.
I mean, I feel like that's going to be a really hard one to do, but Toffel miners are going to be your best friends, probably.
Oh, do you think so?
Yeah. I mean,
Okay.
if those are the cases that are going to happen, like in my brain though, like I'm like, well, I'm really hoping that it's mostly going to be like class 5, the buccal stuff
No.
or occlusals or, things like that. I really have a hard time thinking that you guys are going to be like rebuilding teeth and I mean,
No.
just 'cause
I
it's
more or
scary,
less, if anything at all, what happens is that we're placing the SDF, right? But we still have a hole and they aren't able to clean it out. And so what we were trying to do then was maybe do the SDF, scoop out enough and just kind of pack it with glass ionomer so it wasn't a giant hole for things to get just stuck down in there until they could go. We just want to not have these people extract teeth all the time.
Sure.
And whatever we could do to arrest the decay, buy them some time, explain to them about dental disease, and then they can go get proper restorative work.
Yeah, I mean,
But
we could talk about this off air a
two-
little bit more, but I would say like there needs to be some sort of triage like protocol in place to realize, because even with scoop and fill, if you're scooping and it gets pretty darn close to the nerve, like you almost could do more damage.
Then we weren't.
You know what I mean? Like
No, if they
so-
are like jumping or because we're not anesthetizing them to do this, to scoop and fill. So if anytime there was like any thought that there was a nerve issue, I thought about even just taking like IRM down there and packing it if we felt like there was a nerve issue. What are your thoughts?
Yeah, I feel like glass ionomer is just as good. I don't think
Oh,
you
really?
need to take you're getting some fluoride release and stuff like that anyway. So I mean, and a lot of this stuff, like did Voco send you some samples?
Yeah.
That stuff's pretty darn good. It really is packable. I mean, you're gonna need a little bit of water to kind of help with the stickiness of it still, but just triturate it and get one of those clicker machines, right, to extrude it. And
Clicker machine?
It's not a machine. I said machine. I don't know why, but it's
Like the little handheld thing?
handheld one
The gun?
and then
Okay.
I think that would be just as fine. Just good enough for whatever's going on. I don't think you're gonna need IRM.
See, guys,
also.
this is why if you have restorative knowledge, I need you to come down on these trips with me and teach me some things, because it's one thing for me to be in there doing perio and assisting in extractions, but that's not what I want to do. I want to help these people from losing their teeth, and there's a lot of decay down there, a lot of decay. So, I mean, a lot of perio too. So we're doing scalings for sure. But at the end of the day, these people are extracting teeth because of abscesses. They're broken off, all that kind of stuff. And I want to prevent that for them.
Yeah.
So
our interview today is Frances Tryon, and her and I actually met on a mission trip. And that was kind of our first. We met in Guatemala. I can't remember the year, but it's only been a couple of years. And it was when we were doing the local anesthesia mission trip / CE trip. And when her and I were talking, we were taking a bus down, and I remember one of my first conversations with her, she was talking about how she was using this Perioscope thing, and I had no idea what a Perioscope was at the time.
So jealous.
And she was talking, I think at the time she owned one of her own dental hygiene practice, or something like that. And so anyway, I talked to her some more and just kind of picked her brain a little bit about things. And she's just such a phenomenal and interesting person. She's so well educated. She's just a wonderful human being. She loves to travel. I think her husband is a pilot, and so they get to travel quite a bit. So I see her Facebook posts of all different places across the world. And so I asked her to come on the episode with us. And for this one, I think you were actually, this is at Under One Roof, but you were at the booth or something. And so it's Mike and I think Edie came in a little bit later, and we interviewed Frances all together. Yeah. So anyway, so we hope you guys enjoy this interview with Frances Tryon.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
So, welcome to this interview which is kind of weird because Michelle's not here. I hope you weren't hoping Michelle's going to be here.
Kind of miss her.
No, it's okay. We're going to do some great things without her. But we do have Mike on the mic.
A couple of mics.
Oh, that was a good one. It's early. Francis, thank you for being here, by the way.
You're welcome.
My good old friend, one of the biggest supporters, which I still don't understand to this day. Maybe let's start off with a little bit of background, and then we'll talk about how you and I met.
Okay.
Go ahead and introduce
Oh,
yourself.
am I supposed to say?
I mean, I don't know your background in detail. I might.
My background,
Yeah.
as in hygiene?
Yeah, and who you are, and like where you, everything.
I've been a hygienist for 28 years. I was a dental assistant before that, so I've probably been in dentistry longer than you two have been alive. Fairly close.
No, that was nice of you to say.
I live in Salt Lake, Utah, and practice in Greeley, Colorado.
So I want to talk about that first of all.
Okay.
Well, let's go back to, where'd you go to school?
I went to the University of Colorado.
And
I went to a real school.
as opposed to,
You can delete that if you have to.
no, I don't want to. It's her email address is. Why do you want to be a hygienist? What was the story behind that?
I was a dental assistant, and I thought I want to be a surgical nurse. That's what I really wanted to do. And then I found out they had to work weekends and holidays, and a hygienist made more. And so I thought, maybe I'll go into hygiene. And it has been the best decision I ever made.
Is that right?
So many opportunities in hygiene. If you just look beyond the norm of a clinical setting, there's just so many doors open to hygienists, especially today. The students coming up nowadays will have thousands of opportunities to use their knowledge that they've gotten.
So it's funny because, like, we talk about these things in these little small settings, like, hey, yeah, well, it's so great for these people coming up. But they're always like, there's no jobs, there's no this, and, competition, whatever. How do you think that they should find out about these opportunities that we all see, but that they don't have the opportunity to see yet?
Well, you're interviewing me at RDH Under One Roof, and not to give it a plug, but
No, please give it a plug, because they're giving us this room. So.
Yeah, no, it's one of the best programs for any hygienist to come to, by far. This is my 6th year to come, and I wouldn't miss it. Go talk to suppliers. Go talk to schools. Go talk to, Stronman has a new program for implant coordinators. I mean, it's just one thing after another after another. Just open your eyes and look around.
I feel like a lot of us are pretty introverted, though. So what have been your experiences when you talk to these vendors about their different products, and what kind of questions should you be asking them? Because I feel like a lot of people just come through, grab the sample, and then leave. Right.
I think if you just take the time to talk to them ask them how they got involved. Ask them hygienists know how to talk.
We do have the gift of gab.
We do. So just open it up, because chances are that's another hygienist.
Yeah.
And so talk to them, ask them how they got into it, ask them if they have any ideas. Do they have any programs? So much of these companies now have programs for hygienists. I actually also work for Acteon. I'm a trainer for Acteon. And I just kind of fell into that one, too.
Maybe explain who and what Acteon is.
Acteon has piezos, digital sensors, the Air and Go, the air polisher, and something else that I can't remember. And so I go into an office after they've been sold, and the equipment has been sold, and I go in and train the hygienist or answer questions or things like. It's really a fun job.
That sounds like an awesome job.
It is.
How do you find, like, when you're doing your training, the other hygienists, how do they accept your training?
They accept it real well. It's been fun being able to go in and talk to them. Some of them want to come from a different approach, want to come from a scientific type approach, but all of them are so happy to have the hints and stuff. I mean, it's no different than us. We go in, we have a new piece of equipment the doctor drug in, and you have no clue how to use it. Now, nowadays, you can usually go to YouTube, but it's nice to be able to talk to a professional in the field that has used that piece of equipment, and maybe they've got some hints and ideas that the manufacturer does not have. So that, no, it's been well
received. Do you find that it's mostly the hygienists that are requesting these pieces of equipment coming into the office, or do you find it's mostly doctor, kind of top-down doctor giving you?
That's interesting because it's about half and half. Some of the doctors have bought the equipment. A hygienist has come in, has no idea how to use it. A piezo is a perfect example. Most of us were taught on Cavitrons. And
magnetostrictive.
Right, and so you don't realize how the difference between the two, and the small little things you have to change. Same with
do you mind going over those real quick? I don't know that we've ever talked about that on the podcast.
I was going to say,
so far.
Just in my experience, I worked in prosthodontics, and we had a Cavitron in one room and a piezo in the other. And I had never used a piezo. I learned about it in school, and they, the other hygienist was like, "How do you use this?" It's just like a Cavitron. That was the recommendation that I got, and I was like, okay, it's like a Cavitron. Okay,
it's similar. I went to them because you use a much lighter touch. As a matter of fact, they taught us that you take a tissue, you draw a pencil line in it, and you erase it. That's the touch that you use for a piezo. Okay, so it's a much lighter touch. It shaves the calculus off, unlike your Cavitron knocks it off. The sides, so they go back and forth. The sides are what you use, whereas the Cavitron, you can use all of them. But you can use all of them on a piezo, too. So it is basically the same. The reason I went to it is because they've got so many different tips I can use.
So that's just for different angulations, different areas of the mouth, things like that. How do you rotate out those tips? Is it an insert, or is it unscrew it?
You unscrew it.
And then how's is there a concern with safety? Poking yourself and all that kind of stuff.
Not unless you're you and you poke yourself.
That's a good point. That's
a
great point.
No, because it's all covered. So no. I think it's safer because that tip is always covered. You also use less water with it.
Really?
So I'll go into the other part that I use. I use a Perioscope.
Yes.
And if you don't know what a Perioscope is, it's a little fiber optic camera that goes down below the gum line that I use. Instead of blind scaling, I now have visual scaling and root planing. And so I use that. So I need less water. A lot of hygienists, I shouldn't say a lot of hygienists because there's not a lot of us out there that use it, but if you use a Cavitron and the and the Perioscope, that's a lot of water that you're trying to suck out.
Yeah.
So I went to the piezo because it was less water.
So how did you get into the Perioscope?
I read an article in RDH about a girl that was using it in Washington. And I was so fascinated by it because I thought, that just makes sense. Why do they teach us to do this and we can't even see what we're doing? But we think we got it all, and these people are going to heal? Are you kidding me? And as you know, the more you're in hygiene, the more you realize, you're missing so much. Why are we having to scale and root plane again?
Yes.
So I actually, this woman has an office out in Seattle, and I flew out there and watched her perform. She has people come in from all over, actually the world, to have her do a Perioscope. She does a little different program. She also places M-Gain. If you don't know what M-Gain, talk to Strawman.
Well, yeah, we had Tracy Butler on the episode.
Yes. So we use the M-Gain, what they call off-label. It's not designed to use for that, but you get bone regrowth from it. So anyway, that's how I got into it. I was so fascinated by it. So I went out, bought my own piece of equipment, and at the time, the only thing you could buy were the old ones. This company was started 20-some years ago, and then it was started by some people that weren't dentists, and it went under. So the only equipment out there was equipment that had previously been used, and Dr. Kwan came in, took over the company, and has kept it going. And he now has a new Perioscope out. And a company that I'm associated with is bringing out a new Perioscope actually next week at the Tucson show at
Very
the Arizona.
nice. So did you get a sneak peek of that one? Or you get to use it ahead of time?
I actually have the prototype.
Nice.
Yeah.
I love
So it works off a Surface tablet. So you can record what you're doing. You can.
Very cool.
Yeah. No, it really is.
So, I mean, because the things that you could do with that recording are pretty endless. I mean, patient education. I mean, you yourself, obviously, you need it for your stuff, but that's pretty good. By the way, this is Edie.
Hi, Edie. I don't mean to ignore you.
No, you should. I tried to sneak in. I'm sorry that I'm late. It was kind of a last minute.
Yeah. I was like, Edie, get down here. What are you doing? She's like, I'm in bed. I'm like, what? We have a podcast.
Can you be here in 10 minutes?
Yeah,
I'm like,
get down here.
Okay.
Well, you look really good for somebody who just got out of bed.
Thank you. Don't get
pretty
too
good.
close. I didn't shower.
That's all right.
We're going to edit this, right?
No. All that's going in. Any other embarrassing things you want to say real quick?
No, I'm going to keep my mouth shut.
While we're
for
at
now.
it. So Edie will jump in with some questions, too, probably throughout the thing.
Okay.
So sorry if you hear something coming from that direction.
No, please,
It's just
please.
Edie. No big deal. We were talking about, you have the prototype. So how many years total have you been using the Perioscope?
4, almost 5 years.
And what kind of difference in healing you don't use MDGain though for your stuff, or you do?
No, I do. If it's a
Let's talk about that.
if it's a deep enough pocket. So if it's an 8 or 9 millimeter pocket, I definitely place it.
Okay, so let's talk about the business side of that, because I feel like
Can I ask
purchasing
a quick
MDGain.
question? I'm sorry.
No,
Sorry
yes.
to interrupt, but
This is what you
it's
do,
back
it's
to.
fine.
It is what I do. So if you're working in an 8 or 9 millimeter pocket, do you do that around implants? Like if you have an implant that's failing, can you get in there with the Perioscope, really clean? And I mean, you've got thread, so it's more difficult. Use the MDGain. Have you had any good results with that?
Yes, I have. I do go in there, and I go in there with the implant little thing for my piezo and can clean real good around it. I have never placed MDGain around it just because I don't know how it would react. I would assume it would react the same as around a regular tooth, because that's the whole process of an implant. But I just have never done it. But no, and 9 times out of 10 when I go in around an implant, it's leftover cement. And so once you remove that, it clears up quite a bit.
It's interesting. I work for a prosthodontist, so that was my thinking about it around implants, around people who have these bony defects that we can't figure out why.
Right.
Like all of a sudden, this healthy patient then has a bony defect.
Right, and your only other option is to go cut the gums and go in.
Which is, what they usually do.
Yeah.
So when they do that, are they finding cement left over as well? Because Michelle says the same thing.
Cement or they say there's some bad bacteria or something. We refer them out. They go back to the periodontist, so we don't always get a really clear answer about what was going on subjectively.
Interesting.
Well, that's interesting too, because how do they know what type of bacteria it is and how to treat it if they don't, if they don't test it? So it'd be interesting to know, do they test it? Do they?
Some of the specialists that we work with do. They'll test it and say, well, they
cool.
have we found an overgrowth of this specific bacteria that's causing the problem.
That's interesting. Do they find a lot of systemic things too that can cause it?
I don't think they're looking in that direction. They should be. I think that it's obviously impacting because it's in your mouth. The systemic is impacting, but I haven't spoken to the periodontist about that. No, but those are some questions I'm going to ask.
We might be too far ahead of the periodontist.
Sorry, that was a tangent.
I wasn't trying to slam on them, but I was like, they really. I'd say the same question in my head. Would your doctor allow you to purchase and train on a Perioscope? And
I think my doctor would be way into it. Like he loves new technology. He's always trying to improve. It would depend on the cost.
So, and we will get into that in just a second, but I want to talk about going back to the purchasing of MDGain and things like that as a hygienist and the business side of that part of it, because I feel like we're always told, well, at least in Washington, probably several other states, that, you have to work through your office. They'll contact the dealer or, the supplier, distributor, whatever you want to call it. And there's not really a lot of say that the hygienist has. So how do you get around all of that? Can you work with a particular distributor to get the products you need? Emdogain,
no. You have to, a doctor has to purchase it.
And so how does that collaboration work with you? Like, how do you get that then?
I don't have my independent practice anymore. I used to have an independent practice, but now I actually work under a doctor.
Okay.
So he buys it. And the other, I've never had trouble. I have associations with other doctors, and they'll buy it. I pay them, but and it is pretty expensive stuff.
So does your doctor use it then for other applications as well, or are you the only person in the office that uses it?
I'm the only person that uses it.
Oh, that is so interesting.
Yeah. I'm surprised he doesn't, because, for grafts, it's awesome stuff. But he doesn't do hardly any grafts either, so
really? That
could be why.
Does he do a lot of placing his own implants? And
he does.
All of that? Yeah.
He does.
Is he the one leaving all the cement behind? That's right. Well, that part out. We got that. So that's fine.
He actually does a different procedure so the cement doesn't go down there. It's pretty cool.
Very nice.
Yeah.
Very nice. Let's go back to when you did own your own practice.
Okay.
Because I actually had forgotten that you'd sold or stopped doing whatever you ended up. Let's talk about that, though. When you and I met, we were in Guatemala, which is a great place to meet someone from the States.
It was gorgeous.
Can we talk about that
experience? Yes, it was a great experience.
So some of the listeners might know that I was teaching a course of local anesthesia with Dr. Tommy Murph of Dental Town fame, who does extractions, and he'll bring down 20 to 30 doctors to learn how to do extractions. They'll do kind of like a humanitarian-ish type trip, and it's they'll go to a town in Guatemala. Anyone that has broken down teeth, abscesses, whatever, they'll do extractions only and get them out of pain. And then the hygiene side of it is we have a little bit of didactic stuff that you didn't have the didactic stuff though. Mm-hmm. We've implemented that since. And then we have clinical, which is I think 4 days. We only did 3 days?
We did 3 days, yeah.
I think it's 4 days now.
Wow.
Of clinical and seeing patients. And the hygienist role is to learn about local anesthesia and learn to administer it and get all the patients numb.
It was awesome. I hadn't given, because I'd lived in Texas for so many years, and you don't give anesthesia there. Mm-hmm. So when I moved back to Colorado, I wanted to give it. But, you don't have too many people lining up, practice on me. So when I saw that, I thought, oh, that's pretty neat. I'll go down and, try something new. And it was great. It was great. Andrew was perfect. I could see me shaking to go in there, and he just calm you down. But you just gave injection after injection. The doctors would hop in and say, hey, try this, try that. It was a great experience. Those people were the best, kindest people that you'd ever want to work on. I was truly, truly touched by how humble they are, and it was great. It was a good experience.
I think top to bottom, it's still. I haven't done it in about a year now, and I don't know where my future is with that. There's no hard feelings or anything like that. I got really busy, and hey, I'm sorry I can't come to this one. I'm sorry I can't come to this one. And then now I don't know if it's just more of a expectation. I'm just not going to show up to these things or whatever. But you're right. The people are great to work on. Did you notice the pain tolerance difference?
Unbelievable. Yes. Oh.
Yeah. So if you want to learn how to give injections, give them on these people who are not going to flinch and jump and
they
cry.
They don't. Not at all. I just was in awe of their pain tolerance, especially when I came back to the United States and had one of those big old guys come in my office, and I had to give him an injection. He's whining all over the place.
The biker with tattoos everywhere, and
Oh no, it was so good.
Except for the kids. They kind of cried a little bit.
I didn't do the kids. Andrew got to do those.
And I felt like a barbarian afterwards. They're in pain, right? And there's abscesses or whatever, and they need to get those teeth out. And so, Mike, we were doing.
Well, that's what I was going to say. Did you find it different than what we went through in
I
Yakima?
used some of our techniques that we learned in Yakima to make sure I didn't hurt myself as I was administering anesthetic.
Oh,
But that,
yeah.
for Francis and people who are not used to that type of, administration of anesthetic, it's hard. It's hard to watch.
Oh, it was.
I can't even imagine giving an injection to a little kid. Like, that would be.
Well, I mean, the important part is that everyone's safe, right? I mean, that's the first and foremost. And so because of that, unfortunately, when you're getting consent from parents, you're like, are you sure you really want to do this? Because this is what's going to happen. We are going to have to hold the head still. We're going to have to hold the hands and feet still. And they're going to have to be still so that no one gets poked, especially after reading that one article about that person got poked in the eye. Did you read about her?
No.
Okay, as a quick digression, there was, and this is several years ago, but there was a doctor that was giving anesthetic, and I can't remember exactly the right sequence, so I might be a little bit wrong on this, but I believe that somehow the needle was contaminated, so whether he'd given one injection already or not, the patient wasn't wearing eye protection and dropped the syringe in the eyeball. And so,
My gosh.
yeah, and so,
oh my gosh.
then they decided to go ahead and continue on with the procedure, from what I remember, and she got help later. But it was too late. I think she lost the eye.
Wow.
Because of infection
Because
or
of
because
infection, from what I understand. Yeah. So, having seen that article circulating several years ago, I'm like, oh, well, everyone gets eye protection, and guess what? We're going to be safe about these needles. We're not going to be messed around. And I'm needle phobic anyway, so I'm like, I really don't want to get poked. So yeah, I mean, just making sure that everyone's safe. I think. Yeah, the hands grabbing and things like that are scary, but you got to think about the feet because they can bridge up on their, back and their shoulders and move all sorts of different ways. So, it's usually a 3-person operation: one person to hold the head, one person to hold the hands and feet. And
the feet are a whole lot stronger than the hands.
Yeah,
for sure.
Yeah. And then you just get in there and you just do it, and you do it quick. So,
Did you ever do like a burrito, like take a blanket and wrap them up?
not in Guatemala. We call it a papoose. But in the United States, we have, working in pediatrics, there was a papoose board, and they had to have consent from parents and all of that. And you have to understand also the population that this was. This was, very high risk, high needs, patients who, Mike and I were never involved in this directly, and I can't recall a specific instance, but some of our doctors in the past had to go testify in court for child abuse kind of thing. So, these are those types of patients who absolutely need the help. Otherwise, systemically, they're going to be worse off if they don't get it done. And so, IV sedation isn't always an option for some of these people, and sometimes you just have to strap them down to do the little occlusal filling or whatever, whatever you're going to do, or pulpal debridement. So, anything to add to that, Michael?
Not at all. I never had to go to court to testify, but I had to sign a lot of letters.
Did you end up doing that? Yeah, I never.
When I got into the GA stuff.
Yeah, so that's kind of scary. So our background with local anesthesia and those types of experiences, that's why I didn't really care doing it. I was like, oh, but these kids are still so much stronger than those wussy United States kids. It was great. So anyway, we had a good time. We saw there's some culture. We got a little bit of culture and walked around the city. So.
It was a beautiful country.
Oh man!
And my one other concern besides giving anesthesia, which was a big one, was the language barrier.
Yeah. Yeah.
It really wasn't. It really wasn't at all.
You need very minimal dental Spanish to be able to get by with a lot of these things. And mostly because on our end, we had people that were doing the intake forms and things like that. So that was very helpful. They needed to speak Spanish. But who did we work with? Was it Lions Club? Did they come down with you?
I think that's who it was.
The Lions Club International works with Dr. Murph's team quite a bit. I just couldn't remember which time.
And there was a woman that comes down a lot.
Yeah. Oh, she's gonna kill me. I forgot her name.
Oh, she was.
You want to say Virgie,
cool, but yeah. So you just kind of smiled at him. There's a universal language that we all use, and so if anybody ever wants to do it, don't stop because of language. Language is not an issue.
So for that, everyone, it's weteachextractions.com is the website for Dr. Murph's course. I think. Still.
Does he still take hygienist down?
He does, but it's usually one or two, not the big classes like we were doing for a while. And it's he does a quick didactic portion of it. Like he added a thing to his big slide, his big lecture part. So there's stuff definitely for everyone, and it's not that expensive. Like I know the prices kind of fluctuated a little bit, but I want to say it's right around $500.
Yeah.
Plus all your expenses to fly there and all that kind of stuff. But the $500, I think it's like 48 hours of CE,
right?
More than you're gonna need for your license for a lot of states. So anyway, so we did that, and then you came back and you started using. So you had already had your own practice at that point.
I did. I worked in a practice, and then one day a week is when I did scoping, and that was I actually was able to use his office, so I didn't have the overhead.
Nice.
And he would actually come in and give my injections until I was able to get the injections.
Oh, very nice.
But I had my own equipment. So as far as charging things out, because I know that's where you're headed.
Thank you. I was.
The scaling and root planing part of it was charged to insurance. The scoping, the MDGAIN, that is not covered by insurance. So the patient had to cover that.
So what would a typical conversation be? So do you have a consult with them first, or you've seen them already for another reason? Like how do you get the probing numbers and all that stuff, and then they have to come back for SRP?
Yeah, okay, so if it was a new patient in the practice, somebody else had done the probings. Of course, I always redid them, especially after they're numb, because we get different numbers. If it was a patient that I'd seen for a while and they weren't getting any better, then I would have the conversation with them. We really need to do this. This is what I can do for you. This is the results that we hope to get. This is how much it's going to be.
Yeah.
I find that if you just lay it out there, it's black and white. Sometimes we want to sugarcoat it. It's kind of like buying a car. You just want to go in, tell me how much it is, and move on. You don't want to sit there and
play the game of barter.
Right. So, and I think pretty much everybody's that way. Tell me how much it's going to be. Tell me how much I have to pay. And I don't charge as much as some of the other girls do. And the reason I say girls is because those were the only hygienists I know that have them.
How was case acceptance? Was it a pretty high rate when you just laid everything out like that?
Yes, mainly because these were patients that were going to lose their teeth.
Yeah.
And they didn't want to lose their teeth. And so their choice was to go to the periodontist and have them, slice their gums, do that whole thing. And that was probably double, if not triple, from what I charge. And mine was less invasive. The gum tissue isn't now in recession because they've had to have that surgery. So no, it was very well accepted. Or their other choice was to lose the tooth or teeth.
How did you find the patients that maybe weren't as responsive to your therapy that would maybe go to a periodontist? Did the periodontist support you, or were they kind of bad-mouthing you?
There were a couple that supported me, and then there was a couple that didn't. The ones I find that didn't were the ones that usually did, what's that laser thing they
LANAP.
LANAP. So if they do LANAP, and I have nothing against LANAP, but I have seen calculus left behind from LANAP. So it doesn't, because once again, you're doing it blindly. If they would use the laser with the perioscope, that would only increase, the outcome of it.
And we probably should have someone from LANAP come on and talk to from my understanding is, they're just trying to disinfect basically down there, and they're not concerned necessarily with larger deposits of calculus. Obviously, that's not ideal, but they don't need... Again, I could be misspeaking, but it's, the gross debridement, then laser is... They see a lot of clinical healing because of it.
Right. Supposedly, though, they feel that, with a laser that dries out the calculus, and so it just kind of floats out of there. And it's supposed to somehow... it's supposed to somehow cause bone to regrow. And that part I don't quite understand the science behind. But
I've seen a lot of before and afters with bone regeneration, and I don't understand the science either, but
That's pretty cool.
my thing is like, if it's working on a certain
Right.
particular group of people, then let's keep letting it work. It's not going to be for everybody,
Right.
but just like antibiotics aren't for everybody, you know. Like some people respond really well to a certain family, and some
Right.
people don't.
Right.
So I'm all good with that part.
So,
What's up, Edie?
Nothing. I'm just trying to remember. I took a course about, I want to say 6 years ago, on the eye lays. That it's not LENAP.
Right.
It was laser therapy, and it was basically doing laser curettage. And they were saying you're disinfecting the pocket, and that's why you get the bone regeneration, because you've killed all of the bacteria. And it doesn't matter if there's calculus; it matters that there's not bacteria. But again, this was 6 years ago. So
And we had
it's
Kim
different.
Miller earlier this week, and she was talking about biofilm removal and how important biofilm removal really is to generating health. One of the things that she was mentioning was we need 30 to 60 seconds of ultrasonic instrumentation in the pockets to lyse the cell walls in order for that to happen. So again, using lasers or using ultrasonics to disinfect and kill and whatever, there's different ways we're going about this here.
well, just knowing what I see in the scope, when I go down there and they have biofilm, my picture is extremely cloudy. And so you have to, and it is at least 60 seconds to clean it up. The stuff isn't easy to get off. And for some reason, I think we think biofilm is like plaque. One swipe and it's gone. That is not the case at all. So, yeah, at least 60 seconds to get in there and do something.
You can't just take your cure, your scaler,
No.
and just like scrape off the side of the tooth, and then all the biofilm in that pocket's
Yeah,
gone.
no.
That's not how it works.
No.
So, and that was kind of an interesting thing too, because I feel like Mike and I are still babies in this profession. We've all been out 8 years or something like that, and so that type of information. Like that picture that you just kind of help us like put in our mind. That's interesting because I've never talked to someone who's used Perioscope before, and knowing that you've seen a clinical picture like with your scope of just like that cloudiness.
I probably ought to
That
take
makes-
a picture of it
You
to
should.
show, because that was an eye-opening experience for me to be able to look at and go, why is it like that? And the girl that was training me, she says, that's biofilm.
Yeah.
She says, keep using that ultrasonic in there and it'll clear up. And pretty soon it did.
And when you take the picture, send them to us so we can see them. That
Yeah.
would be pretty
Do
cool.
before and after and all that
I
kind of
should.
stuff.
I should do
That'd
that.
be really awesome.
Are you using an air powder polisher with the glycine powder?
I do, and I usually use it before that, and it does help a lot. It does with the perio tip.
Okay, so
Definitely.
Do you feel like it's faster and more effective at clearing up that biofilm?
Oh, yes.
Okay, because that's what the research says, but
Yes.
you've actually seen it with
Yes.
your eyes.
No,
so.
no. I agree totally with it. Yeah, no, that's a good point.
That's so funny. You just stepped into Michelle's role about research and all that bull crap, and I'm just like, no, anecdotally, tell me exactly what you're seeing, because I like what you have to say. You're so funny, Edie. Good job. Way to be part of this
Thank you.
podcast.
Thanks.
So we're coming up on the end here, and obviously, I could ask you a million questions, and but maybe let's do words of advice, because that's a good one to kind of close up on. Words of advice to established clinicians, maybe new grad students, anything that you see in the whole profession. Doesn't have to be necessarily about the Perioscope, doesn't have to be about anything necessarily that we've talked about.
Words of advice. Well, my biggest one, and it's one I live by, is don't ever stop learning. Whether it's in dental hygiene, whether it's in life, whether it's in religion, whatever it is that you're fascinated with, history, travel, don't stop learning. Go to these places. Go check things out. You're not as dumb as you think you are.
How do you feel about the cost that's involved in doing some really good ones? Do you feel like it's a benefit? Is it worth it?
Marry somebody rich. No.
Everyone's wish.
No, I think the cost is definitely worth it. I do. I wished I had done what you're doing. I wished I'd gone and gotten a master's. And not everybody needs to do that. But I definitely think a hygienist needs to at least have a bachelor's. And so that is my plug. Let's raise our standards a little bit here.
I love it. Princess, I love you. Thank you so much for being here. I'm glad we're friends.
This was
Thanks for
fun.
doing
This was fun.
Very nice.
All right. Thanks, everyone.
Bye.
It's about that time. Grab your blanket and a glass of wine. It's story time with Michelle.
Story time with Michelle is in honor of Perioscope or endoscopes. This is going to come from RDH magazines. They never put, it's volume 33, issue 2. There's never a date on this. I've complained about that to them all the time. But I usually, again, try to go with the journals. I had a different article picked out, but I actually really wanted to discuss endoscopes since that's what y'all were talking about on your interview today. So this is called Visual Career Enhancement. Hygienist describes the benefits of working with dental endoscopes by Kathy Hester Seckman. Imagine that you could look directly at root surfaces 6 or even 12 millimeters down inside a pocket while you're working. Would that make your job easier? How much would you or your employer be willing to invest in training and technology to have that capability? Peggy Chesser, RDH BS of Henderson, Nevada, works in general dental offices as an independent consultant using the perioscopy to perform meticulous direct view scaling and root planing. Lynn Groff, RDH, owns a similar business in California and travels to periodontal offices as a consultant. Nancy Kyle, RDH MS, works for 2 Ohio periodontists where dental endoscopes are using dental endoscopes. Suzanne Newkirk, I know her, of Georgia, works with a periodontist part-time in Washington State and is a perioscopy instructor. First, some definitions and background. An endoscope is a medical imaging device that provides a view inside the human body. A dental endoscope is a specialized endoscope that uses a miniature camera to look into periodontal pockets. Dental endoscopes got their start, according to Chesser, in 2001 with a company called Dental View. A few hundred were sold, but there were some design flaws. The major flaw, Chesser says, was that the method used for water delivery was not conducive to good vision. Many of those original dental endoscopes were moved to a back corner and never used because of the difficulty with vision. What a bummer. When the company failed in the mid-2000s, periodontist John Kwan of Berkeley, California, purchased the rights to the technology and founded Perioscopy. I think that's the proper way of saying it. Perioscopy. Kwan's company installed an external water supply for the perioscope and changed the explorers that held the fiber optic camera. A new model is due out this year, Chesser said, which has better image capability and touchscreen image capturing. Chesser became aware of the possibilities of dental endoscope when the periodontist she worked with decided to dust off their unused perioscope and send their hygienist for a one-on-one training with Dr. Kwan. We were blown away, she says. He could do full mouth endoscopic debridement meticulously, and we could see everything exactly. It was one of those light bulb moments, the most exciting in my 32 years of dentistry. The light bulb turned on, and that's what the moment was for me. We came back to our office and thoroughly excited about technology. God, I'm going to kind of skip down just a little bit. I would love to be able to see that.
Doesn't that sound awesome? Yeah.
Yes. Let's see. They're just kind of interviewing some of those hygienists I mentioned in the beginning. I wanted to get down to, we can talk about Suzanne since I know her. Suzanne Newkirk of Lakemont, Georgia was immediately intrigued the first time she saw the video of the perioscopy system in 2001. I felt as if I was on an underwater adventure with Jacques Cousteau, except we were exploring a subgingival pocket. I knew that someday I would want to utilize perioscopy as part of my hygiene repertoire, but if that were to happen, I would either have to find a dentist who had a perioscope or purchase my own. And at the time, it was selling for $15,000, which was not in my budget, and not in probably many hygienists' budgets. So many states, she said, have some form of general supervision for hygienists outside the traditional dental setting, which provides opportunity for entrepreneurship. For hygienists willing to think outside of the box, I believe the future of perioscopy is limitless. I think that that's really cool. And I actually now, Zest owns perioscopy. And Zest, I don't know if you know, overdentures that have the locator attachments that snap down, the 2 little implants on the... You don't know what I'm talking? You've seen overdentures, right?
I've seen the commercial that says you're not fully clean unless you're Zest fully clean. Like that's how much I know about Zest.
Oh, look at Andrew trying to get funny at 7:30 in the morning.
No, it's just that's what I know.
Well, overdentures with the 2 implants in the mandible usually have these locator type of attachments. They're post. There's a male portion, and then you have the female portion within the denture. Zest has kind of a patent on that clip. So anytime you're seeing overdentures, you're most likely using Zest attachments. And Zest now owns Perioscopes in some roundabout way. And word on the street is that these are still expensive, but they are trying to decrease the price and make the camera better. So, I mean, the technology is, of course, getting better and better for everyone, right? So this hopefully one day will be very affordable, at least for, an office to purchase. Or, there are some people, I believe, up in Vermont area that literally are sending their patients to the hygienist that has the Perioscope.
That's so awesome.
Right? Like for those people that can't get better, or even now with implantitis and cementitis, like that's a new term in implant maintenance is cementitis, because cement is causing so much implant disease. And you can get that Perioscope down there, see if you can bust out that piece of calculus without having to flap the tissue, because it does not always heal well after that. So very cool stuff.
Yeah, very cool.
So we do want to make sure everybody knows that we will be again attending Voices of Dentistry in Scottsdale, Arizona. And what is that?
The January 25th and 26th, I believe. Or is it 26th? Hold on. Please hold. Crap. I had it. 26th and 27th. January 26th and 27th.
Very good. You're going to be there the whole time, possibly. I'm only going to be there that Friday because I have to lecture at USC on Saturday.
You get the opportunity to lecture. You don't have to. You get the opportunity.
You're correct. It's very much an opportunity. I'm very excited about it. I'll be lecturing with Anna Pattison at University of Southern California. Very cool. So if you come, you should definitely come no matter what. But make sure you're there on Friday.
Think about it. I mean, it's not just us. That's all the dental podcasts are going to be. They're all the big ones. And then they're going to bring in some speakers. And so you'll get some pretty good CE content. But also, if you have something that you want to talk about on a podcast and you need to get this information out to the masses, there's a podcast lounge. And what the podcast lounge is, basically, all of us podcasters will be just kind of spread out in this one room. Well, I'll have our setups, and you can just say, hey, let me talk on your podcast. Like, you don't have to pay anything to get onto their podcast or anything like that. You just tell them your story, and then they can use it or not use it at the very end. So it's quite an opportunity if you're an entrepreneur, or if you have, or if you just want some good CE with some just really just relaxed, cool people that do podcasts.
Yep. So check that out, voicesofdentistry.com. Again, it'll be in Scottsdale, Arizona in January. We hope to see you there. Don't forget also to like us on Facebook or give us iTunes reviews. We appreciate when you comment on the episodes, as does the people who the episode is with. You know, we just had Chris Potts on, and people were like giving her shout outs and things like that. That was fantastic. The encouragement is great. Also, sharing our post on Facebook is always helpful. And always feel free to message us via Facebook or at ataleoftwohygienist@gmail.com. Anything else, Andrew? I
think you've covered it. Well done. Good episode.
Yeah, great episode. Y'all have a great week.
Bye.
Bye, y'all. So, scaling the web with Michelle.
No. Nope. You can't have my thing.
Let's try that again.
Just because my name is awesome and your name is mediocre.
I don't know why I always do it too. All right. Look at my hair. Good God.
Oh, you look beautiful.
Story time.